welcome everyone to the third OHCA Investment and Payment Workgroup meeting. We're very excited to have you all. And today we will be continuing our discussion on alternative payment models and the relationship to health equity, and also get into some discussion and examples of alternative payment model standards and kind of brainstorming how we could use these examples to inform the OHCA standards for alternative payment models. So for our agenda today, we'll do welcome, we'll do some updates. We have some changes and additions to our workgroup membership, and then we'll quickly review how we have adjusted the workgroup charter to incorporate or strengthen our approach to health equity. We'll talk about incorporating health equity into alternative payment model adoption, so continuing our conversation from our last meeting, and then we'll get into examples of alternative payment model contracting standards and then criteria to inform the standards. And just a quick reminder of our meeting approach. So we are remote participation only via Teams. We're on the third Wednesday of every month, and feel free to use the reaction emojis, use the chat. We take all your questions and your comments in the chat, and we kind of synthesize them and use them after our meeting. So we really appreciate all the information you've shared in the chat. And so I will just kick it off with workgroup member introductions. So we have two new workgroup members joining us today. Lisa Folberg from the California Academy of Family Physicians. Katrina Reyes was previously our workgroup member and has transitioned to another organization. So we're excited to welcome Lisa. Lisa, would you mind introducing yourself?
And sure. Yeah. Hello and good morning, and thank you for welcoming me into the work group. I will probably spend most of today observing and learning from all of you. I'm the CEO of CAFP and have been in and around health system reform and payment issues for a long time. So I recognize some of the other work group members, and I'm happy to be a part of it.
Great, thank you. And our other new workgroup member is Mohit Ghosh from Anthem or Elevance. Mohit, do you want to introduce yourself?
Hi, everyone. I know a lot of the faces and names on the group. Nice to reacquaint with several of you. I'm with Anthem here in California. Elevance is the enterprise nationally. Obviously, this is very much a part of our mission. We try to do as much value-based work as we can. And getting this right, especially through the lens of equity and geography in California, is very, very important. So we're happy to be part of the discussion. Appreciate it.
Great, thank you. And for all of our kind of ongoing returning workgroup members, we'd welcome you to introduce yourself in the chat. Also, we have, our whole group of team from OHCA and the Friedman Healthcare team. So welcome you all to introduce yourself in the chat as well. We also have a new team member to OHCA, Nan Tran, who is our payment reform manager, who will be supporting a lot of this work. So I'll ask Nan to introduce herself in the chat as well. So thank you all and welcome Mohit and Lisa. We're excited to have you. So getting into our first agenda item, we appreciate all of the feedback we've had so far on the workgroup charter, and we got some feedback between the last meeting on how we could better incorporate health equity into the charter. So we have incorporated in a few places efforts to promote equitable, high quality, and cost-efficient care. So the updated charter was shared with you all along with the workgroup materials and has been posted to our meeting page. And I think we'll just jump right into our content today since we have a lot to get through. But if folks have questions about the charter, we're happy to address those in the chat or via email. Thank you for all your feedback and getting to us to where we are today with the charter. I think it's really helpful and really strong. So with that, I will turn it over to Bob from the Friedman Healthcare team. And Bob, if you want to introduce yourself again, that would be great. And then we can jump into our discussion on health equity and alternative payment model adoption.
Great, thank you, Margaretta. Good morning, everybody. Can everyone hear me? Okay. Thank you. I'm Bob Seifert. I'm working with the Friedman Healthcare team on this project. I'm based in Boston, where I've done a lot of work in the past on state health policy reform and looking at a lot of the issues that this work group is talking about. So I'm very excited to be part of it and to be helpful in any way that I can. Which is so let's start here, I guess, with picking up our discussion that we started in the last few minutes of last month's work group meeting on incorporating health equity into alternative payment model adoption. Of course, Margaretta just mentioned the updated charter, which incorporates stronger language around equity, and we know that equity is an important component of the value that APMs can generate and worthy of specific focus here and in an ongoing way among the work group members. So before we dive into this slide, I want to clarify that I'm going to be using the term equity broadly in this presentation to include, for example, the idea of reducing health and healthcare disparities and the idea of addressing social needs and social determinants of health. And for clarity, I will try to use specific terms when talking about program examples that we're going to get into in a little while. So, by way of reminder from our last meeting, payers and health plans are pursuing equity really at different levels. At a strategic and planning level, by elevating equity as an explicit goal. At a plan design level, by allowing flexibility to provide supplemental benefits. At an operational level, with screening tools, improved data collection, and quality measurements. And finally, in payment mechanics, by adjusting the payments in an APM to motivate improvements in equity. Next slide, please. So please keep these questions in mind as I go through this material today. We're going to turn back to them at the end of this section of the meeting for some discussion. Two very basic questions. Number one, how can equity be incorporated into APM measurement and reporting? And question number two, how can APM contracting standards accelerate the adoption of APMs that encourage high quality, equitable care? Next slide, please. These are some general approaches to promoting health equity through APM design, and then we're going to look at specific examples of these approaches in a moment. So first approach is requiring health plans to improve data on that long acronym I'm sure you all know is members' race, ethnicity, language, and disability status, and sexual orientation and gender identity. The current incompleteness of that data in most places hinders addressing health disparities in access and outcomes among subpopulations. So some payers, mostly Medicaid programs at this point, have offered incentives to improve the data. A second approach is paying for administering a social risk screening tool to learn more about the social factors that members face. Third approach is offering incentives for health plans to partner with community organizations to address some of those social needs. And then finally, risk adjusting payments for social factors, in addition to the traditional payment adjustments for clinical factors such as chronic conditions and for demographic characteristics like age and location. Adding to that, a risk adjustment for explicitly social factors. Next slide, please. This is a map of states that are in some way considering equity in APM payment and measurement. It's a bit complicated. There's a legend on the side there, and you have the slides. But we wanted to show you really just the variety of ways that equity is considered in an APM environment and where that is happening. These are 4 of these are the same categories that were listed on the previous slide, and then there's the addition of category A here, which are states using financial incentives in Medicaid managed care programs for meeting targets or for supporting specific initiatives. The map shows that there is activity in this area, in the Medicaid MCO financial incentives area, in a majority of the states, including California. So let's look at some specific examples starting on the next slide, please. Most state activity in this area right now is in Medicaid programs in a variety of ways. So first, payments for social determinant of health screenings. Most state Medicaid programs already require screening for social determinants. Massachusetts and Rhode Island have gone a step further and include screening performance among their quality metrics for Medicaid managed care organizations. Second, there are a number of different ways that equity incentives to address disparities are used in Medicaid programs. So such things as withholds from capitation payments that are tied to improvements in equity, risk corridor and medical loss ratio adjustments, pay for performance on specific quality measures stratified by race and other factors, and contractual requirements to develop value-based payment strategies. And the states in parentheses there are the ones that are using these different flavors of incentives to improve equity. Third, several states are using Medicaid waiver authority to establish partnerships and to allow managed care entities to pay for health-related social needs. One example here, a good example, is the coordinated care organizations in Oregon, which have equity requirements built into their contracts with the state. And also the CCOs, these coordinated care organizations, can provide actually provide directly food and housing supports for their enrollees. Then another example is from Massachusetts and Minnesota, which adjust their managed care capitation rates for social needs. Minnesota uses available administrative and claims data from the program, while Massachusetts uses those data plus what they call a neighborhood stress score that's built from Census Bureau survey data. And then finally, in the Medicaid category, I just want to note that NCQA, the National Committee for Quality Assurance, which is the organization that maintains and administers HEDIS, which is a well-established and broadly used set of quality and performance measures for assessing managed care plans. Last year, NCQA published a measurement framework for state Medicaid programs to use specifically for measuring health equity in their managed care plans, and made that available to states. The framework includes 6 domains: social interventions, access to care, clinical care, experiences of care, structures of care, and then overall well-being. So a pretty broad spectrum of domains there. And importantly, many of the 21 equity measures that they've put forth within these domains are established, validated HEDIS measures, which states are already using in many cases. Others can be readily adapted for use by health plans. The framework is available, as I mentioned, to state Medicaid programs, though NCQA believes the domains can be adapted to other populations and applied more broadly. And just another point about NCQA is that they also offer a health equity accreditation program to healthcare organizations. Next slide, please. So there are fewer examples outside of Medicaid to look at here, but there are some. In the one example among commercial payers is the Blue Cross Blue Shield of Massachusetts example, which Blue Cross in Massachusetts has just begun to add incentives to reduce disparities to their provider contracts that are part of its alternative quality contract APM strategy, which is about 10 years old. The alternative and this alternative quality contract program has shown improvements in quality measures since its launch. And now Blue Cross is adding specifically a focus on equity to its contract incentives. They're initially going to focus on improving equity in 3 areas: colorectal cancer screening, blood pressure control, diabetes care. And then they'll add categories as the payment model evolves and they identify additional areas of inequity. The new contracts have been signed with 4 of the largest health systems in Massachusetts, and Blue Cross is looking to add these equity provisions to other provider contracts in the future. So that's the commercial side. Next slide, please. We'll take a look at in the Medicare realm. As part of its Maryland primary care program, the state of Maryland has arranged with CMS to be able to pay primary care practices a $110 per member per month fee for Medicare patients with high medical complexity and who live in a neighborhood with a high area deprivation index score. This is another example of, this is a measure of neighborhood socioeconomic disadvantage that the state has developed. The purpose of the payment is to invest in practices serving socioeconomically disadvantaged Medicare populations with the goals of improving outcomes, reducing costs, and advancing health equity. A key feature of the payment is that it is not a payment for performance. That is, the payment is not, at this point anyway, not contingent on quality, utilization, or cost measure, performance, or improvement in those areas. The practices can therefore rely on this payment to make necessary investments. They have used the payments as examples to integrate social needs screening workflows into electronic health records, to create relationships with community-based organizations that are working on food assistance issues, and to hire community health workers. Those are just examples of how some primary care practices in Maryland are using this add-on payment. Let me stop here take a sip of water and pause for a few minutes and see if anyone has any questions or comments. I know that there's been a lot in the chat here. Thoughts about the information I've presented so far. Margareta, can you moderate that?
Yes. I think we've addressed some of the questions in the chat, but I think just in general, OHCA will definitely be looking to align with the DMHC work around health equity for health plans, the DHCS alternative payment model efforts, all of the other state purchasers and departments that are doing lots of work around health equity and alternative payment models. So we will definitely look to align, where it makes sense and where we can. And also, to learn from these programs and everything that's been successful or working in those programs. So any questions for Bob?
So this is Mohit. One of the main things, oh, sorry, I should have raised my hand. I will stop.
Go ahead, and we'll get to you, Reshma, next.
Okay, thank you. Sorry. The data issue here seems to be looming large. I think we need to recognize, even as we do the DMHC quality and equity work on the 12 measures plus the one CAPS measure on that side of the house, as well as, learning from all of the Medi-Cal work that is ongoing, that it's still pretty difficult to get to a RELD SOGI data set that we feel completely comfortable about. So any thoughts around, especially when you're looking at, the entire healthcare sector, not just Medi-Cal, how do we enhance that data collection? Are there thoughts from other states, from the Friedman team? For example, employers might collect some of this data for EEOC purposes, but they're not sharing it with the health plan, just as one example. You know what I mean? So just trying to think through, how do we get to a level of data that we know is realistic?
I think I'll just say quickly, I think that's an issue that we'll all be working on collectively, as we're building up these programs. And I think the more opportunities we have for data sharing is helpful. And I think for our purpose for OHCA, in terms of the alternative payment model standards, I think that's one area where we want to look to, like, do our standards address collecting race, ethnicity, or demographic data broadly, in order to support a greater effort around analyzing data for health disparities, et cetera. And I know we have lots of hand raised, so I think I saw Reshma next, and then Pallav, feel free to, thanks for jumping in the chat.
Yeah, thank you. I actually had a similar question around data. So I think that's a great one, because that's kind of a logistical kind of area, right, around alignment, because we are thinking beyond Medicaid. The other thing was actually related to the slide that's up right now. And we've brought this up a little bit in prior conversations, but especially in the realm of equity. This comes up in the Medicare conversations all the time. But how do we think about onboarding for new groups into new areas? And it's this thought about putting financial penalties or kind of accountability to things. Is there kind of an initial first year track to kind of get started up on the screening and kind of the infrastructure set up for groups that are participating in this? How hard line are we in that first year? And I think the program here brings this up, but I think it's something for us to reflect on as well, because it's, for certain groups, it's going to be a equity in itself based on the resources they have, are going to create differentials across groups in the state.
Yes, good flag. And I think that's definitely something we've been discussing internally, is how do we build our standards so that we encourage smaller practices or folks that are new to alternative payment models feel supported in joining an APM or taking on more risk. So that's definitely a consideration for the alternative payment model standard. And I see Beth.
Hi. Recognizing all the data challenges that are faced on particularly in the commercial market, when we look at race, ethnicity, language, and SOGI. But to complicate it a little more, I think it's important in the commercial market to also be looking at income. And I'm interested that some of these approaches appear to look at income as one of the factors. And that's certainly something known to employers.
Thanks, Beth. Yeah, we're definitely seeing there are some examples of alternative payment models that are using like a social risk tied to payment that can incorporate income.
Right, either individual income or neighborhood, sort of some measure of neighborhood kind of poverty status and so forth.
Yeah, well, employers at least know their own employees' income.
Exactly. Yeah.
And I think next on my list I had Joe.
Hi, yeah, Joe Castiglione here from Blue Shield of California. Just a quick question, I guess really two, but the first one is about what's on the slide here. Can you share more, whether in the context of Maryland or what you expect to do here in California? Can you share more about how the high medical complexity is being measured? Is it all claims, or are you using Medicare HCC coding?
I don't have that information right at hand, but be happy to get that for you and get back to you. I don't know if anybody else on the Friedman team can speak to that. Maybe Mary Jo.
Good morning. Yes, I believe that it is using HCC coding, but we will confirm and put it in the chat in just a second.
Okay, great. Thank you so much. And then one other quick question. Is there a CPT code for the social determinants collection procedure?
Are you referring to like the Z codes that are used regarding certain social status or something different?
So I know Z codes are ICD-10, right?
Right.
But is there a procedural code to map the actual activity that going on there, or no?
Mary Jo, I have a few in mind. I can put a link in the chat in just a minute.
Thanks,
Thank you so much. And that's it for me. Thank you all. Thanks,
Joe. Next, I see on Sarah, if you wanted to jump in with your question.
Yeah, it's more of a comment than a question. In that, further in the slides, I saw a note that a potential implication of APMs and all this discussion is potential consolidation and costs going up. And I think it's also just really important to remember that affordability is also an equity issue, and to not brush over that.
That's a great point.
Yes, thank you. And Carrie.
Can folks hear me?
Yes.
Yeah. Okay, sorry. Yeah, I just really appreciate the conversation, and I can't see the chat, so I don't know. I assume others, have been sharing, but California, I think, is doing a lot of these examples that you're providing around equity, and I appreciate hearing what other states are doing as well. And I guess I'm just wondering, how is OHCA, I know we're sort of talking now about examples, right, of what equity might look like in APMs, but I'm also just curious how other states are looking at and measuring adoption of some of these standards at the provider, level, and and by across lines of business, and by region, et cetera, because I know, I mean, California's marketplace is pretty diverse, and there's very different pockets, and I think, as others mentioned, there are places where there might need to be additional investments. And so I'm just curious, like, how other states are kind of drilling down, or if they are drilling down to that provider and regional level. Thanks.
Thanks, Carrie. Really good question. Bob or Mary Jo, do you have any thoughts?
I'm sorry, Carrie, could you, so you're wondering how states, if we have examples of states looking at some of these issues kind of at a sub-state level? Is that
right? I mean, I think there's the health plan level, and what health plan, what health plans might be requiring, but then sort of drilling down, but to contracts between the health plans and providers, and hospitals and others. I mean, how are these kind of, to what extent are you getting that data and that information?
Yeah, I don't. Let me ask either Mary Jo or Vinayak, they've got some insight into some of the other states that that Friedman has been working in. If you have a sense, I know that the looking at the individual contracts is not sort of that's not commonly done at this point. But some of those other kind of dimensions, I wonder if you could comment on that.
Sure, happy to. I think what I would note is that the collection of this type of data is really nascent. And so I think a lot of states, even those that are collecting this type of information or trying to stand up these types of programs, tend to be very reluctant to report anything at a sub-state or a I'll say, payer level. And so I don't know of a lot of sort of provider level reporting going on regarding this at all. But if others are aware of something I'm not, please feel free to comment or put something in the chat.
Thanks, Mary Jo. And Carrie, we can continue to kind of dig into this question and think about how that applies in California, how we could use the alternative payment model standards, or in terms of our data collection for alternative payment model adoption, how we might try to be a little bit more nuanced. So we'll keep digging into that question. And I think Paula, you've had your hand raised. Go ahead.
I just had one comment and one question. So the comment, just seeing the things in the chat, specifically in terms of SOGI and real data collection, to share the perspective of DHCS, we actually started requiring this of providers as a part of our last 1115 waiver demonstration for all of the public hospitals and associated clinics, and that's continued through. So we're going on about 10 years now. And in my previous life, before joining the department, I actually implemented that policy and SOGI collection on the ground with our providers and patients in clinics. And universally, everyone was so nervous about it. What are the patients going to say? Even talking to my own, 80-year-old Eritrean speaking patients that I'm asking about their sexual orientation and practices. And our universal findings were that the staff were actually much more uncomfortable than the patients. And once we had implemented processes and training, the patients were actually really grateful, and it increased their trust in the provider offices. There was an entire downstream of positive effects from building that as a part of our routine practice. And there's literature, however, it is nascent, but there is literature that also supports this. So just to address some of those comments, I think our experience has generally been really positive. Once you get over the staff and provider discomfort, which is where the bulk of the change management is that we focused on, and less so on the patients. The question is really, I think, as a department, we have been thinking a lot about algorithmic bias and how, if we only use claims and encounter data, that can perpetuate actually some of the equity goals that we are trying to achieve. So would be curious to think how you are thinking about, especially if we're trying to calculate high medical complexity using coding, et cetera, what other options there are to really look outside of claims or use other types of predictive analytics to get at that.
Yeah, really good question. And Mary Jo or Bob, anything you want to add there? And I think that's one thing we'll continue to discuss and wrestle with as we get into the standards.
Yes, I have nothing to add at the moment, but I agree that's something that we should definitely look into.
I'll just add that I think absolutely getting good data here is it has been a challenge. I think it's going to continue to be a challenge. Often in the states where we work, when there are the same individual can have different data on race, ethnicity, et cetera, for the same time period in different data sources. There's also a lot of challenges with standardizing categories across data sources. And so it's just not simple. That being said, I think it's worthwhile. We need to do it. It's just going to take some time. And I think that having sort of those realistic expectations that honestly, when we look back on this 10 years from now, I think we're going to say, wow, we know so much more about how to do this well. But to be honest, I think this is one of those things that we're going to have to try and fail fast and learn and, you know, keep evolving. I hope that's not too negative.
No, thanks, Mary Jo. Adam, Dr. Solomon?
Thank you. So I just wanted to follow up on Plav's comments. I think it's great and a good point that some of the challenges are simply in the comfort of the team asking the questions, but there's still that infrastructure required to make sure that they're asking it in a programmatic fashion, that the EHR is set up to be able to capture that data. And so then there's a time component that gets added to the already pretty burdensome expectations for the providers and the offices to see patients and just provide medical care in addition to all of the quality metrics and the risk capture and all the other work that they need to do. In addition, to some of the hesitancy that some of these patients may have in sharing some of that information, there's also this circular part where these are also the patients that are challenged to even come in and have that opportunity for that information to get captured in the first place. So some of those that have the highest needs are also going to be the ones that are the least likely to get those needs captured. And then lastly, along that line, given all of this work and the additional cost and time, my only other concern is just the potential for letting the perfection of acquiring everything we can do, overwhelming the good we can do by at least getting towards a reliable metric for potential deprivation and social needs in the communities that each of our systems or any of the provider organizations serves.
Thank you, Dr. Solomon. Really good flags. And I think we'll keep going. We have a few more slides here, and before we get to our next agenda item, but yeah, I'll turn it back over to you, Bob, and then we have lots of other points where we'll pause for questions.
Right, thanks. And I think that these last two slides that I have here reflect a lot of the, in a lot of ways, the conversation that's been going on for the last 10 minutes. But let me just run through them really quickly in terms of what we see as some of the lessons learned from looking at some of the initiatives in other states, and providing some food for thought in California, which you're obviously already chewing on. First, it's too early, as Mary Jo made reference to. It's really too early to know in many cases how effective these strategies are in improving equity. So continued monitoring and adjustment are needed. And it's also unclear. This also means that it's unclear what some of the best practices might be for these types of initiatives. A second lesson is that obviously stakeholder buy-in to equity incentives is important. There's generally a support for figuring out how to address equity through payments, but there is a concern, and I think a number of you have touched on this, about capacity and resources. For example, what do you do? What should happen following a positive social needs screen in a clinician's office? Are there resources to be able to address whatever that screen reveals? And the concerns regarding resources and capacity extend from healthcare providers across the community to social services systems and so forth. So where is the ability to kind of meet the needs that are going to be identified by focusing more on some of these equity questions? Third lesson is that there's a line to be walked concerning adjustments particularly around measurement adjustments to avoid penalizing plans and providers that care for high-need patients, but also not, quote unquote, giving them a pass by setting relatively lower performance targets for those plans and providers, or for those patients, I should say. National Quality Forum provides guidance for developing risk adjustment models and includes considerations regarding how payment can be adjusted for providers caring for high-need, high-cost patients. And then regarding misaligned incentives, APM investments in health equity can be hindered by the so-called wrong pockets problem if the benefits of the investments accrue to others in the healthcare system, like a future managed care plan, or even to other sectors, the education system or the criminal justice system, without having a mechanism for sharing those benefits with the entities that made the investment in the first place. Next slide, please. So let me briefly summarize all of this information by suggesting some considerations for California regarding health equity in APM measurement. First, alignment across state agencies. You all know this. There are several state agencies that are taking this on in various ways. We have this work group. We have other venues to support shared learning and collaboration. Second, there are questions about how narrow or broad to make equity-related contract standards. That's an issue we're going to start to look at in the next part of today's meeting. We've already talked about this quite a bit. Data collection practices are evolving. There are considerations here about balancing the data collection burden and the importance of having good data to improve and measure equity. And then the fourth consideration is that while certainly APMs are one potentially effective vehicle for addressing health-related social needs, and as part of realizing that potential, measuring the effectiveness of those investments in improving equity is important. There are also concerns, though, about over-medicalizing social needs and about the trade-offs of funneling more resources to healthcare organizations to treat individual patients' social needs rather than making the structural investments to address the underlying issues of poverty, homelessness, and food insecurity, for example, that's upstream kind of causes of the health problems that come downstream. So that's a sort of a policy tension that needs to be thought about and addressed. The next slide is just a reiteration of the questions that I posed at the outset. I will turn it back to Margareta now to see if there's any time. I think a lot of this has already been sort of started in the previous conversation, but let me finish up here and turn it back to Margareta for whatever direction we're going to head in next. Thank you very much.
Thank you. Yeah, I just want to pause here maybe quickly for questions or thoughts if folks have any further thoughts in terms of, how do we take these lessons learned or these considerations and potentially translate them into measuring and reporting on APM adoption in California or our contracting standards. And I will note we'll spend a lot more time discussing the contracting standards and in our third agenda item. Yes, Beth.
Yeah, recognizing all of the challenges, including the challenges with obtaining data, it does seem really important as we move forward on the conversation on alternative payment models that we are mindful of equity and building it in, and that it needs to reach down to the provider level. We will not have succeeded if we end up making health disparities worse. And I think everybody who's raising concerns about provider burden or data collection knows that, and they're asking these questions in the context of wanting to get to more equitable care. And so, but this needs to translate down to the provider level or will worsen the disparities that currently exist in our healthcare system. Not a question, a comment.
Thanks, Beth. Yeah, Dr. Solomon.
Well, thank you. So also, I think a comment, and I'm trying to combine two different things that we're emphasizing. And so, for example, you can have an organization that predominantly serves a higher socioeconomic population, and then does the additional work of collecting the demographics and collecting the Reggie data, the RELD SOGI data on that population. And then you can have another organization that is in a much more socioeconomically disadvantaged population, which is going to be struggling more and may not perform as well in collecting that data for that exact reason. And I'm concerned that if the emphasis is on the collection and serving of the diversity of the population, that the reward may still be skewed toward that organization with the higher socioeconomic group because their population might be more forthcoming, will be smaller, will be seeking out care, and the ability to close some of those gaps may be easier. And so I'd hate to short shrift those organizations that truly are serving the population that we want to serve. So to me, it seems like it needs to be somewhat separated so that we are supporting the development of APM and the work around managing a population that has a high deprivation index so that they can do good work. And then in addition, a potential higher reward for narrowing disparities within their diverse population. But that's, to me, almost secondary to that first issue, which right now a lot of organizations are struggling with. And you'll see fewer APMs in those areas that actually need it the most, simply for that reason.
Thank you. Yeah, those are very helpful comments in terms of framing our discussion moving forward. And I think that's also what we've seen is there are some, those emerging recommendations to adjust payments, maybe potentially based on social risk, so that folks that are serving higher social risk populations receive more payments under an alternative payment model. But that's, one consideration or potentially one approach. And I know we have a few folks with hands raised, and I think I saw Carrie, or sorry, Dr. Grumbach next, and then Carrie, I'll go to you.
Thanks. I think there's so much in this area, and I think we have to be honest about sort of taking an anti-racist framework as soon as we, are really talking about issues around race, ethnicity, among the other elements of social and environmental factors we're talking around here. So I'd like to really bring it back to what should California really focus on in the context of this discussion, which is around alternative payment models, right? Because there's just a huge area around approaches to health equity overall, the use and misuse of how people identify themselves in the delivery of care and the efforts to improve care, with lots of peril of misuse of identification to move into sort of biologic constructs of healthcare risk and things like that. So I think for us, I'm taking away from this, I would really put my nickel on the payment aspects and how not to structure APNs in a way that just right off the bat disincentivize organizations and practices from caring for patients who have high social needs, which are associated with much higher than healthcare needs and expenditures. So I I would love California to be a leader in this regard, and along with a couple of the other states were mentioned, in really starting to use not just self-reported identification or social risk screening, but frankly, to move to geographic-based assignment of social risk based on the census tract level of where people live, because you can't game that. It doesn't put a burden on the organizations. It doesn't then get into problems with inconsistent collection from one organization to another. It's very objective data, and I think that's where a number of other nations have moved. I don't like the deprivation index. I don't like the language of it, but I think the concepts are very sound. As you look at small areas, it won't tell you exactly that individual's income or whether they're in a community with a high immigrant population or social need, but it will actually be a very good proxy when you look at populations of payments. So I think California could really be a leader in this regard. So that's what I would take away from this. And my recommendation to OHCA and HCI is to really put the initial effort into how to use geocoded base sort of identification of people who are much more likely to have high social needs and incorporate that into payment formulas, which means you actually pay more rather than less, like on Medi-Cal. I mean, the implication would be Medi-Cal should be paying much higher rates than commercial insurance rates, because Medi-Cal patients tend to come from those much more higher need communities. So that would be a radical notion, wouldn't it? But I think the whole issue then of measuring performance, it's really fraught because of all, I mean, there's a lot of literature out there, and I think there's ways you can use payment to try to incentivize at least organizations to try to look at equity patterns and things like that. I just think you have to do it very carefully because you can easily make mistakes. So that's not, I mean, I put in ways that alternative payments can encourage people to start looking at patterns of care and think about what are they doing to address within their practices equity gaps. But I think that takes a lot of care to do. So I'd probably make that number 2 rather than number 1 on my recommendation.
Thank you. This is really, really helpful discussion and content as we start to kind of think about the standards for alternative payment models. And Carrie, did you want to jump in next?
Yeah, actually, I think good timing. I appreciate the previous comments. I actually wanted to flag I think one of our concerns about social indices, and just to say, like, I don't know that OHCA has. I think there's the research is still evolving in this area, so I don't know that OHCA needs to say one way or the other. I think we definitely do though need. We really have to stress that individual encounter level demographic data, and part of why I say that is actually for precisely the reasons that the previous speaker mentioned. The area-based social indices are really good at sort of mimicking, broad census data categories because they're based off of the census data categories. And that works when you're talking about sort of large swaths of the population or certain demographics, but as we saw with the COVID pandemic, it can, if you just do it that way, it really can run the risk of, not getting that granular level data that is needed, particularly for smaller, racially, ethnically diverse populations that are geographically dispersed. And so, UCLA essentially, researchers had to create their own index in order to accurately measure, what was happening, for example, in the Pacific Islander community around, higher death rates and other, COVID-related illness and symptoms. And so I just, would say, yes, it's sort of, that it's, they think that, you know, indices can serve a purpose, but certainly not in a vacuum without, you know, real and SOGI and encounter data that, you know, helps to capture folks that are dispersed. And, you know, we know this is also true for LGBTQ populations and other and disabled populations, other populations that, you know, don't live in neatly within census tracts, to where we can say, you know, that this is, you know, where every investment should go. So I just wanted to flag that as, you know, an issue that we're certainly watching and thinking quite a lot about, because we don't want to leave populations out with sort of a broad swath approach. And I don't think I don't think California would be leading if we were to do that. Thanks.
Thanks, Carrie. And maybe this is one of those instances where it's a both and, is that we you know, we think about how to do both of these things and do potentially, hopefully, both of them well. So I think next I saw Beth. Go ahead.
Actually, I put it in the chat. I just don't want to lose track of the disability piece of the data. It's an important element as well, and those in the disability community and their caregivers, which I would say actually the literature now supports being the caregiver of a person with significant needs is a health challenge, is an important part of the equity conversation as well. So I just didn't want us to leave this without having made that point. Thank you.
Thanks, Beth. And Reshma?
Yeah, mine will be quick because I think a lot of what I wrote in the chat has been reflected by others. But just a couple quick comments. One is about just making sure that whatever we decide, there's a clear strategy around equity in relation to individual patient disparities, but then also at that practice level. So again, pulling back into that infrastructure and kind of, you know, resourcing, and that might be more of the um, adjustments that we think about, or how we think about allowing groups to have some kind of promotion in the program, and it might be in how it's paid, specifically around partnerships with community, because those are the things that often require the most cost and kind of startup funding. The other thing I just wanted to mention is there's a lot of discussion around the adjustment measurement, which I completely agree with everything that's been said, but just calling out rural practices, because the issues specifically around cost and access go hand in hand. And so sometimes their arms are tied. And that notion or that lens we just have to have on it, to Kevin's point about making sure we're not increasing inequity due to kind of the structure of the program that we set up for those practices. And then I just threw in a couple thoughts of just what I've seen of around some of these barriers, and it's not necessarily saying other APM programs have had the outcomes, you know, shown their outcomes yet, but it's just what I've seen other groups jump onto. And one is really thinking about how we incorporate improvement measurement outside of just peer measurement on outcome. And then to the only other comment I think I put in there is CMS has done this where they have self-reported. So they'll say, here are some areas that we want everyone to work on, but you're allowed to self-identify a population that's relevant to you. And that is part of, you know, that gets incorporated. It's a lot more work for the program, that's whoever's running the program on the back end, and kind of structuring data around that. But it does allow subpopulations that certain communities work with that may not be of high volume to get addressed and to count, and to incentivize, I think, some of what Kevin was mentioning as well. So we're not disincentivizing that either.
Thank you, Reshma. Yeah, I think some of that's happening in California too, with DHCS and Covered California, in terms of approach to disparities reduction, being specific to plan's population or things like that. Lisa, go ahead.
Yeah, thanks. I was just reflecting a little bit on what Dr. Solomon was saying and others around the idea of patient comfort. And it seems that one of the advantages of an APM model done right includes and goes beyond just improving care for individuals or even communities to really changing the culture of healthcare. And so I was thinking about that in terms of patient hesitation and the idea of wanting to respect patient boundaries and, not sort of alienate patients, but also using it as an opportunity to look at why are patients hesitant? What about the healthcare experience, practice, environment, process, clinical care, maybe adding to that patient hesitation and being able to have the flexibility and the resources to be able to address those things, which may be as simple as office environment or as complex as clinical care and the clinical questions that are being asked.
Thanks, Lisa. Really good flags. I think we will jump into our next agenda item, and I'll just note that this has been really rich discussion, which means we probably will have shortened time at the end, but I think we'll think about how to focus on agenda item 3 potentially in our next meeting, but maybe we can dig into it a little bit. So I will turn it over to Vinayak to walk us through examples of APM contracting standards and kind of kick off our discussion in brainstorming around how do we get to APM contracting standards for OHCA and for California.
Thanks, Margaret, and thank you all for really awesome participation today. It's very helpful. I think you'll hear a lot of the comments that you've made reflected in some of the examples we look at today. So in this section of the discussion, what we'll really do is highlight some of the current national thinking on how to align multi-payer efforts to promote APMs, and then also review some example APM standards. So we'll walk through a national framework, we'll look at examples from California, and then as well as the rest of the nation. So in the next slide, we're just thinking about, as we review these APM standards and the work to date, we're asking workgroup members to consider, these two questions. Are there additional examples of APM contracting standards that should inform OHCA's work? And then do the HCP LAN's foundational elements of alignment that we'll be discussing now include your organization's priorities for APM contracting? So just hold on to these two thoughts as we delve into the next slide. So one of the very recent reports that's come out in July 2023 is from the Healthcare Payment Learning and Action Network, and they released something called the Multi-Payer Alignment Blueprint. And it's a guide to achieve kind of directional alignment of public and private payers across these 5 foundational areas that you see on the right in the graphic. So the HCP LAN believes that alignment around these elements can help accelerate nationwide value-based care that reduces burden and improves quality. So the blueprint is based on multi-payer alignment initiatives from state transformation collaboratives, and these are based in Arkansas, California, Colorado, and North Carolina. So the collaboratives included payers with input from providers, health systems, purchasers, patient advocates, and community organizations. And it uses the lessons learned from these initiatives and also adds some examples from national efforts. So we're going to delve into these 5 foundational elements for alignment next in the next slide. And here they are listed from that blueprint. Each includes a number of themes that emerge from the collaboratives and in the national examples. So the element containing the widest variety of topics is around the key payment model components piece, and it includes topics like attribution, benchmarking, risk adjustment, and value-based design principles. We'll get into some examples of these in the next few minutes. The next one is performance measurement and reporting, which seeks to standardize measures that identify gaps in care and progress towards a shared set of goals. Next is advancing health equity, seeking to define, measure, and address disparities as well as identify and address social determinants of health that impact outcomes. Then there's timely and consistent data sharing, really enabling data-driven decisions with an eye on uniform access to data and interoperability. And then finally, providing and leveraging technical assistance to enable communication that fosters working towards these shared goals, and then learning from and supporting the opportunities needed to achieve those goals. So these are the foundational elements, and they're present in different ways in APM contracting in California and across the nation. So we'll get into these examples, and we'll use these 5 foundational elements as a structure for today's discussion for these examples, as well as we get into our considerations for APMs in California. So in the next slide, we talk about Integrated Healthcare Association's Align, Measure, Perform, AMP program. And just before I get into the details here, the next few slides focus on examples from California. And so we invite attendees from the organizations we talk about to kind of add to this discussion and answer any questions that come up in the chat as we talk about these slides. So as we dig a little deeper into IHA's AMP program, it uses a common measure set and benchmarks to evaluate provider performance and includes a value-based incentive payment model design that health plans can adopt. So 13 plans and over 200 provider organizations in California participate in the program currently. The providers and plans agree to the measures and submit the necessary data to IHA. Providers are then assessed on clinical quality, patient experience, total cost of care, and appropriate resource use to potentially earn that payment incentive for either attainment or improvement based on design elements that the health plan uses. So kind of both pieces that were mentioned in the chat earlier on some of these goals. And these elements kind of differ for full risk and shared risk provider organizations. So here thinking about kind of the intricacies of practices as well. And there's a special pooling methodology that's also used for some of those smaller provider organizations. And the result is a value-based payment made to provider organizations for achieving and improving on this performance. On the next slide, we'll get into one of Covered California's initiatives on advancing equity, quality, and value. So Covered California has made a number of efforts in their contracting with health plans to move APMs forward. The examples provided here reflect contract requirements for the 2023 measurement year for the individual market plans. There are additional nuances for other markets as well, so just highlighting that here. And these are all focused on promoting APMs. So Covered California has kind of a range of additional requirements that are focused on health disparities reduction as well as behavioral health. And those aren't addressed in these bullets here, but just want to highlight that. Part of what we look at here is Covered California is requiring plans to report on % of primary care providers contracted by HCP land category, and then their associated spending, and to increase the use of value-based payments. So these are all part of their requirements. A key aspect of this work is going to be analyzing plan data and reviewing it for continuous improvement, and working with Covered California to understand the impact of those increased investments and movement to APMs. The next example we talk through is for Medi-Cal managed care contracting requirements. Medi-Cal also has a number of initiatives ongoing, as most of you know, in relation to promoting APM adoption. So similar to Covered California plans, Medi-Cal managed care plans also have some contracting requirements focused on reporting and sharing information on APM arrangements and primary care spending. In addition, they're required to move more primary care clinicians into population-based models. Medi-Cal also has a strong focus on identifying and addressing health disparities by harnessing some of that data and implementing disparities reduction programs. We also know that health plans contracted with CalPERS, the California Public Employees Retirement System, have similar requirements. So in addition to these types of requirements, in January 2024, Medi-Cal will launch its FQHC APM with the goal of driving care delivery transformation through a reformed payment model. The program will allow FQHCs to receive predictable prospective payments while reducing administrative burden through alignment on quality measures and to provide integrated whole person care. Before we move to some of our examples here, just wanted to open up for folks from IHA, Covered California, Medi-Cal, any additional comments that you'd like to make on some of these programs before we get into examples from other states across the nation.
The only thing I would add, which I think people are tracking, is that for the first two bullets, we on the state side have done a lot to really align the contract language almost 100% so that there is broad spread state alignment across Covered California, CalPERS, and DHCS very intentionally to reduce sort of reporting burden and streamline that process for providers. For FQHC APM, not surprisingly, there are just more federal restrictions on how much we can do in this space. And so that program does look different. We are still exploring alignment, but we have sort of much more strict guardrails federally on that front.
Thanks, Paul. Appreciate the alignment, and I think it really helps this work group's work going forward as well. All right, I see Beth, I think you have a comment.
Yeah, just that, as I understand it, the task facing OHCA with respect to the APM is to set standards, not to impose contracting requirements. And I do think that one of the things, and certainly this came up on the DMHC equity quality measures, is that, you know, the advantage of a contracting environment is you can adjust annually. And so we'll have somewhat different constraints on the work here, and Margreta who explained this to me, can correct me if I got it wrong. But I do think it's, you know, the flexibility, the year-to-year flexibility in contracting, which doesn't feel that way when you're in the middle of those discussions, but it is pretty different than the task we're charged with.
Yes. Thanks for flagging, Beth. And you've got that right. Yeah, that our charge is quite different in terms of setting standards for alternative payment models that can be used as, you know, best practices for healthcare entities in terms of their contracting efforts, and kind of how do we kind of create some coordination or focus around a set of standards that we can all agree on and that we can align around, but I think we really want to learn from, you know, the other state agencies and think about, you know, what makes sense for us all to align around or for us all to adopt.
No argument with that. It's an important distinction, and I think when we get to primary care and behavioral health, we'll be dealing in a slightly different environment again. So just as folks think about this.
Yeah. And Carrie, did you have a comment or a question?
Yeah, I also appreciate the conversation about sort of what what OHCA's charge is here. And I guess I'm just curious, and maybe it's early in the conversation, but, you know, I know we have the HCP LAN categories, and it you know, it sounds like we're trying to sort of decide, you know, are these the appropriate standards? Do we need to add other standards? But I guess I'm just wondering if, well, so, you know, I want to affirm that's sort of the question that we're asking. But then, and if that is the question, are we suggesting that, you know, is OHCA thinking that if a purchaser doesn't meet the California standards that they would fail to implement an APM, or would we still be sort of basing, you know, the evaluation on sort of the broader HCP LAN standards? Maybe it's early to ask this, but I guess I'm just wondering because, you know, we sort of have that as a starting place, and I'm not sure. I'm not sure how we're even doing in California at sort of meeting those basic standards.
Sure, Carrie. So I think I can maybe try to clarify, and other folks can jump in here from Friedman, but we have been looking at least kind of at a high level, that the HCP land categories are a way to collect data and to collect information on alternative payment model adoption. So how do you know what the prevalence is of APMs in California? And as we talked about previously, maybe there are some adjustments or additions we could make to those HCP land categories to have them be more nuanced, and so we could, more fully capture kind of all the different types of payment models in California. So we've been thinking about HCP land a little bit as like a data collection mechanism for alternative payment model adoption, and that these standards are more about like how are you structuring your APM contracts? What's included? Like, what are some best practices that we can align around in terms of alternative payment models? Like, how do you look at performance measurement? How do you look at the payment design? How do you look at health equity in an alternative payment model arrangement? So they're much more, I guess, maybe content focused and less focused on the actual like data collection and number of alternative payment model contracts in California.
I'll just add one quick piece to that, and it's that what we're talking about today, this multi-payer alignment blueprint, is what HCP Land has put forward as some foundational elements to support us in thinking about those contracting standards that OHCA will develop. But none of what we've reviewed today are standards in themselves. What we have reviewed are some examples from programs in California that, because we would like to continue that alignment work. And so that's why we're talking about the blueprint in particular and its foundational elements.
Thanks. I hope that helps a little bit. Dr. Solomon?
Thank you. Just a comment on the year-to-year contracting. My experience in these types of arrangements are the benefits to the patients in being in these arrangements accrue over the course of years, and multi-year contracts are important, or at least multi-year relationships that are under these kinds of contracts, so that those patients can start to get the care that they need, feel comfortable with the system, and so forth. The other comment is that a lot of what we're looking at has been around the activities involved in performing or collecting data for managing the population, but the layer above that is the identification and attribution of the population. And I may be missing it, but I don't see that here. And I want to bring it up because to me, it's very important. I've been involved with attribution models, designated models of ACOs, both in the commercial and in the senior population, as well as managed care. And those attribution models are a big struggle. The patients don't necessarily know they're in an ACO. They haven't picked a health system. They're not aware. They don't necessarily understand. And you can see a lot of turnover because of the timing of that attribution. So in one of our commercial ACOs, where it was just an attribution model, we would see 40% turnover quarterly. And so how we determine that attribution or association and the transparency of that with each organization that then is held responsible for the activities of management to me, just can't be ignored. It is very important for us to identify the value of those activities.
Thank you. Yeah, that's something we've talked about a little bit internally in terms of should the standards incorporate something around attribution models, or at least that transparency piece in terms of making it really clear. to all those involved. Good flag. I'll turn to the next slide, and Vinayak, I think we have a few more examples to walk through, and then we'll probably pause here, and we have lots to think about from all the discussion to inform the standards moving forward.
Great, thanks, Margaret. And Dr. Solomon agree on that one too. A number of the examples we're looking at, including this one, do include some thoughts on attribution there. So these examples here, as we look at these, are national examples of APM contracting standards. The first one is from the American Academy of Family Physicians, and it's focused on principles to guide value-based payments, specifically in primary care. So one of the key payment model components is to share the performance-based payments with care teams to reward all members of the team to really align those incentives. AFP focuses on advancing health equity by asking payers and providers to consider risk adjustment methodologies for payment that incorporate demographic factors and social determinants of health. Another growing area of interest which we've been talking about and we'll come back to as well as we talk about OHCA's work here. The next example here is the National Association for Accountable Care Organizations, which provides a few additional key payment model component alignment considerations. One of these is ensuring that there's transparency into the methodologies, the calculations, and the results of all APM arrangement evaluation processes. This is another area where attribution does fit into what some of their principles are noting. They also highlight that it's important to acknowledge the barrier to entry into an APM, which is something that we've discussed in the chat and as in comments, particularly when providers switch from fee-for-service arrangements and to reward that participation accordingly. And so these examples of principles for contracting standards are there to really guide payers and providers in achieving alignment to promote value-based payments. So on the next slide, what we'll do is go into some of those example standards that are state-focused and recommended contracting standards to promote APMs. In this first example, these are recommendations put forward by the Colorado Primary Care Reform Collaborative in their 2023 annual report. And they really include aligning quality metrics, as we've all been discussing, for performance evaluation and improvement, and then incorporating social factors in risk adjustment methodologies as well. Next, as we look at the New York State Medicaid redesign team, they put forward considerations in their path to value-based payment report. The team really highlights the importance of evaluation and by technical assistance for successful implementation. And it also highlights the concept of awarding both improved performance and continued high performance. This is similar to IHA's attainment and improvement incentive that we discussed a minute ago. So as we think through these examples, on the next slide, we have a number of kind of lessons learned. And so these examples we reviewed provide, our work group in California with a number of lessons learned to think about as we think about our contracting standards. One of the key lessons is that accountability mechanisms, whether that comes through transparency or contracting or legislative or regulatory action, really need to be aligned. This can be difficult due to the private nature of contracting, but these types of work groups and alignment across payers are something that can really foster that work. A next key piece here is that care transformation is often a costly process and very involved for providers. So it's important to improve efficiency and reduce that administrative burden through alignment across private and public initiatives. Next, as we think about some types of APM models, they're quite difficult for smaller providers to achieve, particularly as we talked about on the data collection and reporting side. And so it's important for that to be considered as well. And to safeguard against that, contracting standards may need to take provider size, capacity, and resources into account. So now, as we think about what we just reviewed, on our next slide, we have those questions we asked you to think about. And so, informed by kind of our discussion today and your input now, I'd like to just open it up for folks to, talk to us about whether there are any additional examples that your organization has found relevant, and whether these foundational elements we've discussed kind of align with your priorities for contracting.
Maybe put another way, are there any like big picture concepts that you all feel like we haven't addressed so far in terms of, you know, inclusion in an APM, or sorry, APM, contracting approaches? Yes, Kevin?
I think we are settling the notion of our job here is to try to help with principles, right? And standards, as I think Beth brought this up, not get too much like we're not writing contracts in this committee. So I think it might be helpful, reflect on this conversation, to put those principles in certain categories. Maybe it was what I was getting to earlier and people are talking about. One would be, that the payment are structured in a way that do not provide perverse incentives not to want to include patients with high medical needs, which are usually, associated with high, with social, marginalized social factors. So like that's one category. Okay, what are the principles to make sure that APMs aren't structured in a way that motivate, care people providing care to not, have incentives to care for, and related to not have the resources to be able to adequately care for those. So those are the front end. And then I think there's some others about how do we invest in enhancing the capacity of organizations and care provider practices to promote equity in how they deliver care for the patients in their practice, which is a bit of a different thing. And I think that's like, is there a role for pay for performance? How do you use that in a what? What are the principles for how one might think about applying pay for performance related to that? Is it more about, I think, as Reshma said, improvements in equity rather than absolute, targets that you're aiming for? So I think I would find that helpful, sort of, the payment risk, the model, so it's aligned with the idea of being motivated and resourced to care for populations with greater needs, how you structure incentives, and then non-payment models, but accountability. And that's where, what are the regulatory requirements about collecting data and reporting data, and what are the principles that would apply for that? And how do you then say, if we're going to do that, let's make sure a principle is acknowledging the cost and the effort required to be able to comply with things like recording patient-reported identities in a way that's accountable to patients and to their true way that they see themselves, and doing it in a systematic way. So I think right now what's presented, it's kind of a lot all over the place, right? So I think it would be like, what are the principles divided into these sort of categories of different aspects of how APMs can leverage and either promote or potentially perversely worsen inequities.
Thank you, Kevin. Yeah, those are really great points and really good flags for us as we move forward. And maybe just real quickly, Reshma, did you want to add something? And then I think we will wrap up and discuss next steps.
Yeah, really quick. So I think it's really helpful as outlining what else is happening through different programs and across the country in different states. But one thing we haven't touched on that I think would be really helpful is how, because I actually only know this for the Medicare space. I don't actually know what other states are doing around this, but around onboarding and tracks. So again, thinking about kind of those practices that are starting from a different spot than most others. We haven't really focused any slides specifically on that. And I don't know, it's maybe because they're not doing it in the same way, but I think onboarding probably they are, but having different tracks for maybe, helping practices to kind of get up to speed, what that looks like in more detail. That would just be a request.
Okay, great. Yeah, we can definitely look into that. So I think based on all this really great conversation, and sorry, did someone else? I think a few things for us. We will most likely follow up via email and share some information with you all via email before our next meeting and collect any written feedback you all have. We did propose some criteria for the alternative payment model standards in terms of like what could guide us in developing these standards, maybe a little bit different from principles, but something along those lines in terms of what are we thinking about in terms of criteria for the alternative payment model standards. And then the OHCA team, supported by Friedman, will really start to draft some standards, and we may bring those back at our next meeting, or potentially maybe start with just criteria and more high-level thinking. So we'll get back to you all about next steps, most likely via email and in our next meeting. And I think with that, I'll wrap it up. And again, always welcome you all to send me any written feedback, any emails, any questions, and we'll try to get back to you all as soon as possible. And we use all of the information in the chat and the conversations to inform our work moving forward. So thank you all. Thanks for a really great discussion, and thanks for staying over.
Thank you.
Thank you.